What are some of the things that you get excited about, or that people can do, or that we can cross our fingers for to help these kind of things get even more into fruition and hopefully ultimately reduce the cost of healthcare for all of us?
Yeah. So look, I think at the end of the day, we don't sell ourselves or position ourselves as an AI organization, right?
No, no, yeah.
We are a people first organization. This will always be a people first organization because that's the nature of the work, right?
100%.
You have to build the trust. These conversations that we're having with patients about their, quite frankly, financial situations are quite complicated and quite sensitive. And that's the thing I'm most proud, quite frankly, before I move on to answer your question. I'm most proud of our certified patient navigator team, of which we have about 75. They are so warm. They understand how to make a patient feel heard. They validate well. They're very, very well trained in motivational interviewing. So like these things, maybe an AI eventually can learn the lingo in a way that will work. But it's going to be really hard to replace that in-person human warmth, right? So it all starts there. I will say that.
And in that capacity, you don't want to replace it,
Right.
But yeah, 100%. I'm glad you said that. But I'm thinking even more broadly within LinkedIn and Link Health, but even as you as Alister, where you because I know the tech. I think the identification process for one is one, because I'm curious how you even identify these people to be able to have them enlisted or considered for this program. Those kind of things, and then also anything else you can conceive outside of that. Like it's really going to help, I think, just narrow our lens.
Yep.
Or the clarity on where we need to focus.
Yeah. So there are two things that I would say as what sort of we all could do in this moment that we're in. The first is directly related to AI, and the second is actually more policy. And I apologize, I'm going to get a little wonky, but I got to be a little specific. You know what I mean? I'm not talking vague terms here. Yeah, the first with regard to AI, if you're not using these tools yesterday, I'm sorry. It's too late. It's not that AI will replace you necessarily. It's that a human using AI will replace you. And so I think, so that's why I said at the beginning, when it comes to our hiring practices, by doing the last round of performance task interviews for a new position we're hiring for, we're asking people, demonstrate to us how you use AI on a daily basis in a concrete way, professionally, personally, and then show us, walk us through it. Like, you need to be good at AI for us to hire you. So what I would say to the listeners out there is take time, learn, try it out on your next project, figure out how you might use some of these large language. And I have no dog in the fight. Use Gemini, use Claude, use OpenAI. One thing I would say to the sort of broader market or economy is we need more upskilling types of programs to get people quickly brought up to speed on how to use these large language models, because I think very soon it's going to be, just like our organization, it's going to be a prerequisite for many organizations moving forward. So what I would love to see is the rapid development and proliferation of free courses that have certifications that say, Sanjay Juneja has just gone through the large language model, process in healthcare delivery and is ready to work using large language models. That's a business that somebody's got to create tomorrow, right? On the policy side, so the work that we're doing right now is really only funded through contracts. And it's funding through city and state contracts, right? Because city governments, state governments, they really want their residents on these federal, public assistance programs, right? Because they know it's actually better for them as a city. Think of it sort of from a perspective of a economically savvy, right, politician who's trying to balance the budget in their own city or their own state. They're saying, well, hold up, we got all this money over here in the federal government, and I got my residents in my city here. Like, yeah, hell yeah, please, let's get them onto this program. So that's basically how we fund our work. But that can't be the sustainable long-term future. So where we are going, I'm very excited to say this, is we are beginning to bill Medicare and Medicaid for these services. Why? Because ultimately, come back to what we said. If you give somebody, look at that research study that I told you about earlier, randomized control trial, $200 a month. If you give people $200 a month, you see ER visits decline, you see hospitalizations decline. And if those are Medicaid patients, you bet your bottom dollar that Medicaid is going to be recouping those costs, right? Those savings. So we've worked out deals. We've signed 2 contracts to begin to bill for these services. So the big policy piece that I would urge, folks listening to this is, keep the pressure on, policymakers to not let those reimbursement pathways go away. Because if you cannot get reimbursed for this work, no one's going to do it, right? So those are the 2 things that I would say is that on the first, really taking seriously this moment that we're at. It feels a little bit like, I don't know if listeners are surfers, but, sometimes when a wave when you're out there paddling and a wave is coming, you just kind of know, like, I got to start paddling right now. Otherwise, I'm going to be taken over. Like, this is the moment to start paddling. If you haven't already, to catch this wave. And then on the second, the policy side, we need the reimbursement to be maintained so that this work can continue to be valued in the way that it should be.